you. Thank you to Professor Kanahan and for organizing the meeting, and you for moderating. And Amir, it was very nice talk. But as you know, there are several ways to skin the cat. And just to start, I would like to say that probably some of you know, but maybe most of you don't know, but in the late 90s, we used to do a lot of these combined presigmoid transversarium approach to the whole clivus and to the petroclival region, in which we exposed the vertebral artery over C1 and in the foramen transversarium, and sometimes we mobilized it in order to get a better angle of exposure to the lower and mid clivus. But lately, I would say probably in the last 7-10 years, I have realized that many of the operations that I used to do by being very aggressive with bone removal and doing some degree of condyle removal, condyle drilling, they're really not necessary. And we really contend that the majority of craniovertebral junction tumor may be safely approached using simple surgical approaches, provided that microneurosurgical fundamentals are used. Fundamentals, everybody knows what fundamentals are. They are the root of any human endeavor. And it's very important to define and to master the neurosurgical fundamental. The most important thing when you are dealing with benign extraaxial tumor is to respect the arachnoidal plane. Why? Because outside the arachnoidal plane or inside the subarachnoid space, there are usually the vascular and nervous structure that you need to preserve if you want to accomplish a good outcome. In order to respect the arachnoidal plane, you need to be able to separate it and to dissect it from the tumor. So you need to limit coagulation, because if you coagulate, especially at the interface between the tumor and the arachnoid, then you lose the crispness that allows you to do a good arachnoidal separation. Then you need to be able to approach the tumors from different angles. And because what is possible from one angle is not possible from another one. And sometimes, we have a tendency to overcommit to one direction of attack on the tumor. Then you must have a clear surgical plane and a clear goal, but at the same time, that must be mitigated by what you encounter at surgery. So you must be prepared to change your plane. And you must be aware of other modalities to control tumors, like radiosurgery. And radiosurgery is not only gamma knife. I mean, obviously, giving gamma knife a good dose of gamma knife radiation to a tumor in the cavernous sinus or to a tumor close to the optic nerve is not really ideal. But radiosurgery is also fractionated stereotactic radiosurgery, in which you give up to 5 fractions that allows you to be more gentle on the vascular and nervous structure that are inside the radiosurgical field. So I'm going to show you a couple of tumors. All these tumors, they were operated with the patient in the semi-sitting position, and all of them, the incision was either a midline incision or a paramedian incision, and we removed as necessary the posterior arch of C1, but we never went into the occipital condyle. But another 2 important things that probably is worthwhile to emphasize is A, that we removed the horizontal portion of the occipital squama all the way to the posterior lateral part of the jugular foramen. So that's the horizontal portion of the occipital squama. The occipital bone in the posterior fossa has 2 parts. There's a vertical part and then an horizontal part. When you remove the horizontal part, then you get to the craniovertebral junction, to the dural craniovertebral junction, number 1. Number 2, all these patients, they are operating in the semi-sitting position. So that allows you some degree of flexibility in surgery, because you may change the height and the inclination of the table. So that gives you a complete different perspective. You may change your angle of view. I just wanted, in the interest of time, I'll show you just two patients that I think are quite interesting. I think this patient here, number 10, is an hypoglossal meningioma. And I'll show you the... Now, this patient was operated again in my sitting position, and the incision, it was the one that I described before. It's a very simple one, so it takes really nothing to to get to the tumor. And you can see here, the opening of the dura at the craniovertebral junction. You can see this one here is the dura over the cerebellum, and you can see that we have completely removed the horizontal portion of the occipital squama, and now we are opening the dura at the craniovertebral junction. And you can see the very nice exposure, the arachnoidal dissection across spica. Sometimes we need to support the cerebellar tonsil because as the patient is in a semi-sitting position, they tend to come down. And we always use neuronavigation, and we use the focal point. We use the focal point of the microscope as the visual neuronavigation tip. So that's really, it's very ergonomically, it's very efficient. So you can see here we are approaching the tumor. And here we are starting removing the tumor using microsurgical technique, and then the debulking with the PUSA, and all the things that we all know. And let me see if there is anything. Yeah, this one is another patient that I really did not want to show now. So let me go back here. So this one is, this tumor here, this hypoglossal meningioma, was completely removed, and I will just show you let's somehow go back to the other one. But anyway, the tumor was completely removed, and the patient did well. Of course, she had a hypoglossal nerve deficit before surgery that she made unchanged afterwards. This one is probably even a more interesting case. This one is a patient with a small tumor we thought was a meningioma that is all the way in the anterior portion of the foramen magnum. And again, we have done the same exposure. And you can see again the posterior fossa, the dura covering the cerebellum, and the dura of the craniovertebral junction. And this one here is the receptor supporting the tonsils. Again, open of the arachnoid, we get all the CSF out. Of course, another advantage of the semi-sitting position is that the CSF gets out. So, and you are able to keep the arachnoidal dissection without need to suction or to do any other maneuver. So you can see this is the cervicomedullary junction, that the cerebellar tonsils, that's spica. We use neuronavigation to identify a good angle of attack, and then we use the endoscope in order to confirm, that this is a good corridor to attack the tumor. And then once we have confirmed that, then we start working on that, and you can see that the only retractor that we use, and I really think that retractor is getting a very bad reputation today. I mean, I don't think it's a four-letter words, So I think that as long as you do it in a judicious way, retraction is very fine. And you can see here we are approaching the tumor, and we are removing the tumor using, as usual, a combination of microsurgical technique, and we're also using the PUSA to debulk it. But this one is a very small, as you can realize, it's very high magnification. It's a very small window, is probably less than 8-9 millimeter. Yeah, we just let it play for a little bit more. And again, you can see the advantage of the sitting position. The bleeding from the meningioma just doesn't need to be coagulated because it just drains down. So that really makes surgery easier. And also, you don't need to coagulate. And as I said before, coagulation is something that we try to avoid as much as possible because that, it takes away the crispness of the surgical plane. And here, again, and this tumor was interesting because we discussed how to operate this tumor, and many people were skeptical that we could get to this tumor with a simple, approach, and there were consideration of doing a extended endoscopic approach with removal of the odontoid. And the patient then decided to select this particular approach, and that's why and that's the video of the operation. You can see here the tumor has been removed, and right now I think there are a few seconds where we place again the endoscope inside just to make sure that we have removed completely the tumor. And when we use the endoscope, we inject the image of the endoscope into the ocular of the microscope, so we don't need to move our head and look up to the endoscopic image. So you can see here we have not disturbed anything. That's the endoscope going in and showing that the area, the tumor has been completely removed. And we were quite happy with this resection. And I think the next few seconds, next 10 seconds, will show you your pre and post-op MRI showing that the tumor has been completely removed. And now I just would like, for the interest of time, I'm just going back to the text slide. And again, so it's very what we wanted to show is that if you respect the arachnoidal plane, if you limit coagulation, if you approach tumor from different angles, if you use technology appropriately, like the neuronavigation, using neuronavigation under the microscope, really, you cannot do it using a handheld probe because that's ergonomically, it's very ineffective. And B, you need to move back and forth from looking into the ocular and looking to the navigation screen. And also there is a need for a clear surgical plane. And again, you need to be prepared to change your plane and be aware of other modalities to control tumors. And remember, radiosurgery is not only single fracture radiosurgery, but radiosurgery, especially for skull-based tumor that are close to vital structure, optic nerve or other important nerves. There is fractionated stereotactic radiosurgery that is very effective and that has certainly lower morbidity than gamma knife, unless you decrease the dose of the gamma knife and then you decrease the chances of curing the patient. So if the conclusion is that, and I really liked very much the talk by Amir Dedashi, but if microneurosurgical fundamental properly mastered, then the majority of craniovertebral junction tumor may be safely operated using what we think are minimalistic surgical approaches. I think the surgical positioning is very important. The semi-sitting position may be changed. You can incline. You can change the angle of the table, and by changing the angle of the table, you change the viewing angle into the surgical field from a flat one to an angle that may go from down up and from an angle that may go from lateral to medial. So I think if you use all these surgical technique and surgical if you want to call them tricks, call them surgical tricks, then you would be able to really expose a lot of this tumor and take them out very effectively using very simple surgical technique. You know, when you do the extensive dissection of the suboccipital muscle that Amir so brilliantly showed, you know, patients do have a lot of pain post-op, a lot of pain. And I know that from my personal experience, because as I said, in you know, the beginning of this century, we used to do a lot of this approach, and you know, the patient really, they had a lot of pain. Doing a simple surgical incision, either midline or paramedian, it's very well tolerated by the patient. So I will conclude my talk now, and if there are any questions, I'll be glad to answer them.